I don't know about the duodenum. I don't think it's ever going to get a decade. But addiction is a brain disease. It's clearly understood, and more is constantly being learned. But in the real world, we still have this epidemic, and people die. So we have advances, actually, in computerization, medication, counseling advances. But is that impacting practice? Is it doing anything to reverse stigma? Is it improving our policies and our budgets? And are we saving lives with the science? So let's take a quick look at what we know from the science. But I'm also going to get to what we do not know and wish we did know. So we know that there are neurotransmitters. We know about beta endorphin and how it triggers the dopamine circuitry of reward. Great, but there are other systems, GABA, glutamate, the excitatory system, serotonin, which is so important in mood and anxiety regulation, and others like the steroid system, which is part of the stress response hormone system. And all of these are interconnected. So it's a very complex science. It's not just about dopamine. But all of the neurotransmitter systems and the circuitry connecting them are critical for driving behavior. And it's not enough to control neurotransmitters in the brain. We also have to impact behavior. So if an individual is having trouble with impulse control, we need ways to promote maturation. We need sanctions to counter the excessive impulsivity. If the patient is having trouble with stress and coping, we need support and counseling. If the patient is driven for novelty seeking and getting into trouble, we need opportunity to give them reasons to take chances, to take risks with learning new skills, with getting a job, developing a career. For younger people, we need services like Outward Bound to give them something to use that novelty-seeking drive for in a healthy direction. And when it comes to excessive reward for drugs, we have to counteract that excessive reward with things like reward for healthy behavior, also known as contingency management. So I've taken a role in all of these different directions and trying to engage entrepreneurs, investors, equity people to help us translate the science into practice. And we're constantly learning more. There's new areas. In addition to the receptors and the neurotransmitters, we have tools, not just agonists, the drugs like morphine, which means methadone or buprenorphine, but also the antagonists, the blockers, like extended-release naltrexone. But there's much more science coming out, including about immunologic treatments, vaccines against, for instance, cocaine or heroin. That's actually within the realm of possibility. Beyond that, gene vectors, actual ways to change genes in the brain. We have new behavioral paradigms like behavioral economics, and those can translate into therapies. CBT, cognitive behavioral treatment, contingency management. And we can even use technologies to transform systems. I'm going to mention physician health programs, because physician health programs are the most effective systems we have in this country. And collaborative care, which was mentioned briefly a little while ago too. So we don't just have to use pills. We don't just have to use isolated counseling models. We can change the whole system. And as I said, the best system for treatment we have is physician substance abuse recovery treatment. All 50 states have physician health programs. 80 to 90% of physicians who have been addicted to substances are sober and stable 5 years later. That is a success rate that is comparable to any cancer treatment we have. Why don't we get respect? Why are we stigmatized as not being effective? Because we don't use the effective systems of treatment that we just heard about. So if we could implement the balance of supports and monitoring and sanctions and incentives, we would be able to bring that 80 to 90% success rate and 5-year outcomes measurement to all of our patients. But what would that do to practice? How would you like to be held to the standard of how are your patients doing 5 years later? Who in this room is prepared to stand up and say, I have the answer to that question with our data from our program? We don't have that. We have to get that. And if we don't have good answers, then we have to do what the cancer doctors did. And that is find the science, put the science into practice, change how we do our work. Because we can get there. Doctors aren't easier to treat, they're harder to treat. They're smart, they know how to get access to drugs, they know how to hide their use of drugs. They're tough to treat, but we just have good treatments for them. And it's not just about the money, because the savings would more than pay for any of the costs. So we have this epidemic, and we're not reaching people. 33,000 deaths from opiate medications in this country in 1 year. And by the way, you think that's terrible? Did anybody remember alcohol deaths? Because that's several times greater. And we're not reacting like there's a crisis there. We just go along with, well, you know, you have to deal with that. And only 1 in 10 of the 21 million people with addiction are getting treated for them. So it is an emergency, it is a crisis. We need to do a lot more. And implementing the science is an important strategy for fixing that. So I'm going to talk about 3 advances. In computerization, we have a health IT revolution. Pretty much every single one of us in the room, when we go to our primary care physician, he or she is sitting in front of a computer when they see us. But we're not doing that in our work with people with addictions. Where is addiction in the health IT revolution? Medication. So we have these treatments. Why aren't we using them? The FDA says they're safe, they're effective, but only a fraction are getting medication in addiction treatment. And we have the most effective counseling technique is called contingency management, CM. And over 90% of our programs in America don't even use any of it. How does that make sense? So there is a challenge from science to practice. And we don't get away with just saying, well, we have quality in our care from, our own perspective. That's like this guy. I did it. I found a substitute for quality. So let me start with computerization in assessment and patient treatment tracking. And I'm going to describe the ASAM criteria quickly. It's decision rules for who should get which level of care, the least intensive with the best outcomes. And there's now a short version of it, a 10-minute triage version, co-triage. There is the full standardized assessment, a structured interview, and an algorithm for the medical necessity criteria. It can automate utilization review. In fact, Aetna is now designing a pilot study with treatment programs. One of the programs interested in doing this is in your state, Watershed, to eliminate telephone prior authorization for commercially insured patients by instead just doing the structured assessment and having the data transmit to the insurance company. So we can improve our tracking of patients, our placement of patients. We can eliminate the wasteful telephone process and standardize our care and get outcomes. And then we can improve outcomes because you can't fix what you can't measure. So if we measure, we can focus where we want to fix things. We can improve budgets by changing our practice. So ASAM has had numerous studies conducted with NIH money. 25 to 300% reductions in no-show rate to step-down care by using this approach. 30% reductions in 3-month dropout from treatment. Think of all the churn, the turnover, the reassessment of patients, the impact on morale of all this dropout that your counselors suffer from that could be eliminated to such an extent with these significant findings. If you look at 3 months later, people who were assessed at baseline with this system have 3-fold improvement in their addiction severity outcomes and 25% increases in the number of patients ready for step down compared to the seat of the pants kind of intuitive assessment and placement in whatever bed we have available. So we could not only be improving care, but we could increase patient flow. We could increase program revenues. We could decrease the staff burden and improve morale. And programs that use this software found they could speed up utilization review, prior authorization, and have a more successful rate of getting UR approval and prior authorization approval. How did they do that? Well, what's so great about this software? Well, one thing it does is it improves the questioning, even by novice counselors. So if you want to assess if somebody has withdrawal, and you're not a doctor, and you're not a nurse, and you haven't worked in a detox, but you have a patient coming into your program in withdrawal, how do you measure that and decide, do they need meds? Do they need residential care? So what you do is you go to the assessment and